Unlike other diuretics, osmotic diuretics do not interfere with electrolyte reabsorption mechanisms within the kidney. Instead, they directly increase the osmolarity or solute concentration within the blood and tubular filtrate of the nephron or functional unit of the kidney. This results in a strong osmotic gradient, causing water to move from the extravascular space, or outside the blood vessel, to the intravascular space, or inside the blood vessel, increasing blood volume. The increased blood volume and molecules of the osmotic diuretic are then freely filtered at the glomerulus. Due to poor reabsorption, the molecules of the osmotic diuretic remain in the filtrate, increasing filtrate osmolarity. This causes decreased water reabsorption, resulting in aquaresis, or significant water loss with little to no effect on electrolytes. Therefore, osmotic diuretics significantly reduce extravascular fluid volume. The most commonly used osmotic diuretic is mannitol, and it is administered intravenously. It reaches its peak effect within the first or second hour, and effects can last up to 6 to 8 hours. Osmotic diuretics are typically not administered orally due to poor absorption and the potential for osmotic diarrhea. Osmotic diuretics are most commonly used to treat cerebral edema associated with elevated intracranial pressure, or ICP. Because osmotic diuretics do not pass the blood-brain barrier, they can draw fluid away from the brain, decreasing edema and thus ICP. Another common use is for acute glaucoma, as they can also reduce intraocular pressure by removing fluid from the eyes. Osmotic diuretics can cause different adverse effects based on whether kidney function is normal or impaired. In individuals with normal kidney function, osmotic diuretics can cause hypovolemia, or low blood volume, and dehydration, which can sometimes lead to low blood pressure due to significant water loss. Whereas in those with impaired kidney function, osmotic diuretics can cause hypervolemia, or high blood volume, due to fluid accumulation in the intravascular space, due to oliguria, or decreased urine output. Hypervolemia can also result in fluid leakage from the intravascular space, leading to pulmonary edema. Furthermore, osmotic diuretics cause hypernatremia, or high serum sodium in those with normal kidney function, whereas those with impaired kidney function, it can cause hyponatremia, or low serum sodium. This is due to the concentration of sodium relative to the fluid volume in the blood. Osmotic diuretics can also cause hypokalemia, which the dilutional effects of hypervolemia can further exacerbate. Osmotic diuretics are contraindicated with anuria, or absence of urine production, severe dehydration, and active intracranial bleeding, since the medication can potentially cross the blood-brain barrier through the damaged blood vessel and draw fluid into the brain, increasing ICP. Mannitol has the potential to crystallize. If this occurs, a new bottle should be obtained. Additionally, orders for mannitol typically include a parameter for holding the dose. This is usually when serum osmolality exceeds 320 milliosmol per kilogram. Routine blood work to measure electrolytes such as sodium and potassium are also generally completed. Furthermore, it is important to monitor urine output closely, as urine output less than 30 to 50 milliliters per hour should be reported to the MRP, as the medication may need to be reevaluated. I hope you found this video useful, and if you did, please let me know by giving this video a thumbs up, subscribing, and leaving a comment below. Thank you, and bye!